Is HER2 low a biomarker of response, or is HER2 low a true distinct entity in breast oncology?
So first I will go a little bit back for a little historical perspective, because there was one large phase 3 trial that not everybody is aware of that specifically enrolled patients with HER2 low breast cancer. And that was NSABP B-47, which was a trial. You know, we knew that trastuzumab, blocking HER2 with an antibody, was highly effective in HER2 positive breast cancer. And so the idea was, is adjuvant trastuzumab also helpful for HER2 low breast cancer? So they ran this large 3,000 plus patient phase 3 trial, randomizing patients to adjuvant trastuzumab or adjuvant standard of care, no trastuzumab. Only HER2 low breast cancer, no benefit. You see the DFS curves, overall survival curves, overlapping. To me, that's the biggest sign that HER2 low expression is not the driver of these tumors. You know, if these tumors have got or more receptors expressed, usually those are the key driver, together with other, of course, intracellular pathways. In triple negative disease, usually tumors are more complex, and you can see P53 that is mutated, other genes, cell cycles, but in truth, HER2 low does not seem to be a driver in these tumors. But it's definitely a target. It's there on the cell, waiting for us to have the right drug to deliver chemotherapy, utilizing it with a Trojan horse mechanism of action. So I do think that we still can learn something about all this, and we're starting to use novel techniques to dissect really those tumors that do not express HER2, which are very few, because even when you don't see it, it's usually there. You gotta be very fine in order to find those HER2 null tumors. And probably there is some slight difference there, but we're talking of things that are not actionable in the clinic, and right now I think it shouldn't be considered a distinct subtype HER2 low, especially in light of Destiny Breast 06, the latest kid on the block. Destiny Breast 04 showed that in patients with mostly hormone receptor positive disease that have progressed on chemotherapy, T-DXd is better than further chemotherapy. So the question is, what if I take T-DXd earlier? So I take a population of patients with hormone receptor positive metastatic breast cancer, all of which have already been treated with endocrine treatment, most of them also CDK4/6 inhibitors, and I test as first cytotoxic treatment T-DXd compared with chemotherapy. In this case, the chemos that we use most oftenly, capecitabine or a taxane.
But capecitabine was the most common one used.
Of course, which is what we do in clinical practice. Usually capecitabine is what we use right after endocrine treatment because it's an oral treatment, it works well, it doesn't come with much alopecia. But the idea was like, can we test something that may be more potent, more effective than capecitabine in the first line, or taxanes? And beyond that, there was kind of this bold attempt. Like, besides treating patients with hormone receptor positive HER2 low breast cancer, can we also test this exploratory 150 patient cohort with this new thing of HER2 ultra-low breast cancer? So what do we mean with ultra-low? We mean HER2 0, what has been always considered to be HER2 0, where the pathologist is still able to find on the slide at least 1% of HER2 staining. And it sounds confusing, but in truth, we're realizing that, you know, with trastuzumab, with other anti-HER2 drugs, we never cared about HER2 0 versus 1+. It was the same, it was negative. But with these drugs, we need to become finer. And so even within the 0, you can find some HER2 expressing tumors. And so those tumors that are called 0, but still have got some HER2 staining on the slide detected by a pathologist, between 1 and 10% of the cells showing HER2 expression, now we call them HER2 ultra-low. And last year we did this kind of experiment of putting together many different minds of oncologists, pathologists from around the world, trying to figure out these questions. Should we call this new entity HER2 ultra-low or just lump it in with HER2 low, etc.? There was so much discussion, but in the end it feels like for the moment it could be considered different in terms as a target, not as a biologic subtype, but as a target, a different and like targetable subtype that we call ultra-low. But things may change. Things change all the time. For the moment, what ended up becoming the ESMO consensus statements published last year on Annals of Oncology recommend to add this, let's say, intermediate level of HER2 expression. And so now we have HER2 positive, 3+ or 2+ amplified, HER2 low, there is 2+ non-amplified and 1+. Then we have ultralow, there is 0 with some expression. And then we have HER2 null, where there is 0, but where the pathologist can see nothing, just blue, no pink. There is no HER2 on the HER2 slide.